going to define the concept of acute aortic syndrome, to review distinctive features and diagnostic clues, natural history and management, and also to provide appropriate differential diagnosis, highlighting imaging clues for differentiation. As an overall, acute aortic syndrome is a concept that was defined. It's a group of heterogeneous diseases, and basically it's consistent of aortic dissection, and something that I'm going to talk at the end of my talk, which is incomplete dissection, which is sort of like a new concept, although it's not that new, intramural hematoma and penetrating aortic ulcer. And all these diseases share a common clinical profile consistent of chest pain and severe arterial hypertension. You and I know that among patients with chest pain, acute aortic syndrome has the highest mortality. Although the prevalence is larger with acute coronary syndrome, the mortality seems to be higher with this group of diseases. And this drawing is very nice to sort of understand what happened with each one of the concepts here. I want just to draw your attention. All of them can result in aortic rupture, and that's obviously our main concern. But what I want you to see is that penetrating aortic ulcer can evolve to a classic dissection or to intramural hematoma. However, the opposite is not true. A classic dissection and intramural hematoma don't evolve to penetrating aortic ulcer. You're going to find in the literature some other terms to refer to this, and for example, all of these terms have been generally coined like dissections type 1, 2, 3, and 4, and I'm just mentioning this very briefly so you guys know that this terminology also exists out there. And before diving into each one of these concepts, I want you guys to consider this case. This is not a SAM question, but I just want you to try to answer the question in your mind. So to your left, you're going to see, this is the same patient. To your left, you see a contrast, a CT without contrast, and to your right, one with contrast. So in the non-contrast image, what you're going to see is that crescentic hyperdensity. But then when you put contrast in, you're going to see that there's a dissection on the descending aorta. So the questions here are, first of all, which is the diagnosis here? Second, how are we going to classify? Is this an aortic, an ascending problem or a descending problem, or both? And then the third question, obviously, is the treatment. How are we going to treat this surgically or medically? And that's what I'm going to try to answer over the next few minutes. So I'm not going to talk specifically very much about imaging for general purposes, other than to say that chest radiography continues to be the screening method, especially because it's good to identify other sources of chest pain rather than to have good sensitivity to detect aortic syndrome. And generally speaking, CTA, MRA, and transesophageal echocardiography are equivalent to diagnose acute aortic syndrome and their complications. So the first pathology we're going to talk about is aortic dissection. I'm pretty sure you all have seen many cases of aortic dissection. By definition, we need to have an entrance tear. Usually that entrance tear will be located in the right lateral ascending aorta or in the proximal descending aorta. And always you're going to see an intimomedial flap, which basically divides the true and the false lumen. Occasionally, you can have in some cases, you're going to also have a reentrance tear. However, you don't always see this last feature. We all know what is the classification for aortic dissection. You can stick to whichever one you use with your surgeon. I personally use the Stanford. Basically, what you need to know or to put in your report is whether if it is affecting the ascending aorta or not. Very briefly, let's talk about the evolution of aortic dissection and the imaging manifestation of that evolution. And the first and probably the most common one is that you're going to have an entrance tear and a reentrance tear. And that's what it's also called the double barrel aorta, where the true lumen is smaller in diameter than the false lumen. And here I'm showing two examples. This is a type A dissection where you can see the entrance tear, and this is the true and the false lumen. And there's a reentrance tear in a different case in the descending aorta here shown with the arrowhead. Occasionally, there's not going to be a reentrance there, but a cul-de-sac. And in these cases, you're going to have variable degree of partial of thrombosis, be partial or total thrombosis. But still, the true lumen is going to be way smaller than the false lumen. Remember that sometimes you're going to see dissection in images without contrast, and you can see that as displacement of intimal calcifications, but once you put contrast on board, you're going to see the intimomedial flap. Another important feature, especially in these days of endovascular therapy, is to identify the true lumen from the false lumen. Two helpful signs are the big sign and the cobweb sign. Here is the big sign, which is no other thing than an acute angulation that you're going to see in the side of the false lumen. And the cobweb sign is these linear hypodensities that are usually located on the side of the false lumen, like is shown in these two cases with the arrows. Very rarely, there's going to be early thrombosis, and in those cases, the true lumen is going to be way larger than the false lumen. And actually, I do not have an example of that, but it's important to mention this because you're going to see cases of intramural hematoma, and I'm going to talk about that shortly, that it looks exactly like this in CTAs. And the only way to make the difference is just to go to a non-contrast, the CT without contrast. Another potential or very fear complication of aortic dissection is a contained aortic rupture. Generally speaking, what you're going to see is a crescentic periaortic hematoma, like you're seeing here. Some people call this impending rupture. In reality, it's already a rupture. It's a contained rupture. Patients who don't contain the rupture will die at Zin usually. This usually entails a poor hemodynamic status and has a very increased mortality, so it's important to recognize it. I noticed that my residents sometimes get a little bit confused on how to differentiate this from an intramural hematoma. And usually what I told them is, when you're dealing with an intramural hematoma, you're dealing with something that is usually a segmental hyperdensity rather than just a focal abnormality or a focal hyperdensity like in this case. And you can verify that by doing your multiplanar reformations. Aortic rupture, occasionally you're going to see it. It's more common in the ascending aorta. Obviously, the rupture occurs at the level of the false lumen, and you're going to be dealing with hemopericardium and tamponade physiology. Very occasionally, you're going to see cases of active bleeding. This is a case of ascending aortic dissection with a hyperdense pericardial effusion consistent with a hemopericardium in a patient with tamponade physiology, and this is one of those unusual cases where you're going to see active bleeding. You have a dissection that is not very well seen in this MIP reformation, but what I'm trying to exemplify here is the presence of this active bleeding, which was associated with a tremendously large mediastinal hematoma. One very important thing that you guys want to describe in your report is the presence of compression of the true lumen. It entails a dismal prognosis, and it's associated with visceral malperfusion. Basically, what you're going to see is this C-shaped configuration of the true lumen. Sometimes it's going to be like a slit-like configuration of the true lumen. And in the same case that you're seeing here, I'm going to show you a lower level where basically you don't see the true lumen at all, but you can see that there is lack of perfusion of the left kidney and some early defects on the right kidney. This has a very bad prognosis. We need to put it in the report, and it means, something worse is happening with this patient. Let's switch gears here and let's talk about the intramural hematoma. Intramural hematoma, generally speaking, is responsible of 10 to 30% of all cases of acute aortic syndrome. The pathophysiology of this entity is related to what it's been described to rhexis of the vasa vasorum, which is no other thing than just bleeding of the vasa vasorum. Occasionally, you can see in the setting of trauma, but that's not the most common etiology. You can also see it in the literature like non-communicating aortic dissection. And basically, we're not going to have an entrance there or a re-entrance there in these cases. Basically, it's not communicated. That's the reason why it's called non-communicating. And it's important to understand that there's some limitations of imaging in these cases, because we're not going to be able to differentiate this from thrombose dissection, basically. Generally speaking, intramural hematoma is going to be seen in non-enhanced chest CT, like a crescentic hyperdensity, like you're seeing here. And if you go to CTA, you're going to see some thickening, some concentric or crescentic thickening of the aorta, like it's seen in here. There's going to be lack of connection with the lumen, no flow enhancement, and the classification is exactly the same classification that we use for aortic dissection, so basically type A and type B. One important thing is that intramural hematoma is going to be generally associated with a decrease in the diameter of the aortic lumen. Like you can see here, there's a little bit of an abrupt change where the intramural hematoma ends. And that's a feature that is very classic of intramural hematoma as well. Now, this is the case that I showed you before, showing you other potential evolutions of intramural hematoma. Obviously, it can evolve to aortic rupture with, hemomediastinum, hemopericardium, and tamponade physiology, but it can also migrate to aortic dissection, which is what I'm showing here, is the case that I already showed you. Now, these cases needs to be classified like a type A pathology, and we need to pay attention to the ascending aorta rather than what's happening, or more importantly than what is happening in the descending aorta. However, I have to say that there are some papers coming from the Korean literature where these patients with type A intramural hematoma are treated medically with very good prognosis. So, there's this Asian factor that it's described in the literature that we need to pay attention, and that it needs to be further studied. Now, we can also see in intramural hematoma spontaneous resolution. It's more common in type B, like the one that I'm showing here. This is an intramural hematoma with the crescentic hyperdensity and the crescentic thickening in this contrast enhanced. And then a month after that, there's complete resolution of the intramural hematoma. This happens, it's not the most common pattern, but it happens. And then you can also see progression of the disease, like in this case where you have an intramural hematoma, and then a few weeks after that, we have a follow-up showing that the intramural hematoma is enlarging. These patients can also evolve to aneurysm or can remain stable for months. Switching to penetrating aortic ulcer, it's a penetrating atherosclerotic ulcer. Basically, there's an intimal tear with extension into the media. It's more common in the descending thoracic aorta. Could be single or multiple. And it could be associated with intramural hematoma. And there's a little bit of confusion here because then, it looks like an intramural hematoma. And some people refer to penetrating aortic ulcer with intramural hemorrhage like an intramural hematoma, which is not necessarily incorrect, but it's a little bit of a different pathology. The treatment, it's a little bit of controversial, and it depends basically on the patient's symptoms, and some surgeons have different approaches. Some of them will follow the patient, some of them will treat them with endovascular therapy or surgery. Now, what is the definition of penetrating aortic ulcer from the imaging point of view? It's a collection of contrast that extends beyond the expected aortic confines. In non-enhanced chest CT, we can see intramural hematoma, as I already mentioned. In the CTA, we're going to see crescentic thickening, but we also are going to identify a ulceration or a penetrating aortic ulcer. In this case, this collection of contrast is extending beyond the aortic confines. Here's another case that has intramural hematoma, and when we go to the contrast image, we're going to see that there's a little ulceration here in the aortic arch, consistent with a penetrating aortic ulcer. Important to make the difference with just a ulcerated plaque. The ulcerated plaque is just a plaque ulcerated. It's nothing related to extending beyond the confine or the expected confines of the aorta. Here's another classic example of a type A penetrating aortic ulcer with intramural hematoma. You can see all the bleeding here in the aortic arch extending from the ascending aorta to the descending aorta. And here in the contrast CT, you can see that there's a little ulceration at the level of the descending thoracic aorta, consistent with a penetrating aortic ulcer. Here's another case of a different evolution of a patient with a prior penetrating ulcer who developed a saccular aneurysm. This is a well-known evolution of this entity as well. Another one is the aortic rupture. Again, it could be contained or it could be total rupture. In this case, I'm showing you a case of a contained rupture. There is a retrocrural hematoma here in the image without contrast. And then once you put contrast on board, you can see that there is an ulceration at the level of the descending aorta. It depends on how bad the perforation and how contained it is, you're going to have mediastinal hematoma, which could be focal or diffuse, hemothorax, and hemopericardium. This is another pattern of evolution, which is towards the aortic dissection. You can see the penetrating aortic ulcer here. Now, when we have aortic dissection coming from a penetrating aortic ulcer, usually the dissection is a short segment, but oftentimes we can't basically tell the difference. It just looks like an aortic dissection. Finally, a concept that when I review this talk for this meeting, I just came across with this concept, which has been a while, in the literature, and I was not aware, is this incomplete dissection. So these patients have an entrance tear, but they don't have significant intimomedial flap. So we're not going to see an intimomedial flap. It usually happens above the left coronary ostium. And I think this is one of the problems. In the acute phase, it's associated with subadventitial hematoma. And I think basically it looks like an intramural hematoma. So I think I've seen some of these cases, but I never knew this concept before. In the chronic phase, we're going to just have this little bulging of the lateral portion of the aorta. And I don't have cases of this. As a matter of fact, checking the literature, there is no CT and MR correlation in the literature. This has been described by the cardiologist, unfortunately. But what you can see in the angiography and echocardiography is a dilated aorta with this eccentric bulge that you can see here. And I have another case that was provided by Dr. Cirillo in Italy, which is even better seen here. You can see this little bulge of the aorta, and that is called a contained aortic rupture. We don't know what's the really course of this, and we don't know how we're going to handle this. So is it worth to make the diagnosis? I don't know how to answer the question, but I think we're going to be hearing about this more and more as some more publications are available. Now, these patients can evolve to aortic rupture or to classic dissection, as you can expect it. So that's the end of my talk. Just as a conclusion, just want to highlight that acute aortic syndrome encompasses a wide variety of different entities that share a similar clinical profile and can ultimately result in aortic rupture, and that's the reason why we need to be aware of this. Remember that penetrating aortic ulcer and intramural hematoma can evolve to aortic dissection, but the opposite is not true. And then be aware that there is this entity that has been actually in the literature for a while, but unfortunately, there's not a lot of literature on MR and CT, and I think it's just part of it is lack of recognizing this pathology.